Ani, Bonjour, Seiko. This is Jody. Welcome back to Using Our Voice. This is a series of presentations about speaking up about the unfair poor care within the healthcare system and the harm that Indigenous people experience. In these modules, we're connecting this unfair poor care and these harms directly to racism towards Indigenous people. So in this module, what we're going to be looking at is the pathway to harm, and we're going to be using this pathway to harm to support us in recognizing when racism is having potential influence. So first off, we're going to start off remembering what is racism. It's avoidable and unfair actions that further disadvantage the disadvantaged or further advantage the advantaged. So another way of saying this is racism is avoidable and unfair actions that are going to put down or oppress those individuals that are already marginalized or oppressed. And racism can further privilege those that are privileged, so those that are advantaged. Racism can add to those advantages, boost those advantages that those people experience. And again, these are avoidable and unfair actions that are justified based on those different racial groups or the difference in ethnicity. Just going back to the first module, we talked about the roots of racism towards Indigenous people. We mentioned some of the things that show up in Canadian state documents. So documentation, government documents from the mid-1800s that describe Indigenous people as mentally inferior, childlike, unpredictable, untrustworthy, and violent. So First Peoples Second Class treatment, it is explicit in saying the colonization of what is now known as Canada required at its core racist beliefs about and practices towards Indigenous people. So settlers were not coming in and seeing Indigenous people as equal, as human even. They were seeing Indigenous people as less than, as inferior, and that justified a lot of the inhumane treatment that Indigenous people experience. So keep in mind these, I'm going to call them colonial narratives. You'll see when we talk about the pathway to harm, these are ideologies, so worldviews, perspectives, if you will. Indigenous people are mentally inferior, they're childlike, they're unpredictable, untrustworthy, and violent. So mid-1800s, we're approaching, another decade or two, we're approaching the mid-2000s, 200 years ago. This is what Indigenous people were thought of. So again, we reviewed the different types of racism, talked about in First Peoples Second Class treatment. Like I mentioned before, there's way more types of racism, but we're focusing on these four. We're focusing on systemic racism, also known as structural or institutional, epistemic racism, so the difference in valuing knowledge and defining what knowledge is. Interpersonal racism, so relational, what shows up in interactions between people. And internalized racism, so racism that one would have towards their own racial group. So building on that, we're going to introduce the pathway to harm in a little bit more detail. I like to remember the pathway to harm as bias, stereotypes, prejudice, and discrimination. Bias, to me, it talks about those differing worldviews. You'll see in the diagram that it's referenced as colonial ideologies, so worldviews or ways of thinking, colonial ways of thinking. Sometimes you'll hear me describe this first step as colonial narratives. So going back to what the settlers actually thought at the time of colonization. So those colonial narratives that have persisted and continue to have influence today. So we'll go into each of these in a little bit more detail. Here here's the diagram I was speaking about. So this is an adaptation done by Dr. Cheryl Ward. Dr. Ward is a well-known scholar in anti-Indigenous racism, the actual creative mind behind the Sanyas Indigenous Cultural Safety Training Program, a world-led or world-recognized training program in anti-Indigenous racism, so specifically anti-racism based on transformative learning, a really well-known and effective training program. This diagram she's adapted from some work that she came across in her research. So this pathway to harm, it starts with this colonial ideology or this colonial way of thinking, these colonial narratives, these worldviews. Now, I replace this, for the own ease of my memory, because it's easier for me to remember bias than it is to remember colonial ideology. I think of bias in thinking that there's one worldview that is superior to others. So, in the case of colonization and in society today, it's that settler or that white, worldview that's superior. So the pathway to harm starts with those worldviews. Those worldviews, they develop stereotypes. So out of those worldviews come stereotypes or common beliefs. Out of those stereotypes come prejudice. So attitudes. And out of prejudice comes discrimination. So, this prejudice in action. So that discrimination is what's causing so much harm to Indigenous patients within the healthcare system. And it's as a result of that racism towards Indigenous people that's coming from that prejudice, those stereotypes, and those colonial narratives or that bias. There's an example here to, put the pathway to harm, describe it a little bit more, starting off with the colonial ideology or the colonial narrative, the way of thinking, the worldview. They are inferior to us. So speaking about Indigenous people, they are inferior to us. This might be something that a settler would be saying. Indigenous people are just inferior. The stereotype that would come from that, the beliefs, they're all drunks. Well, we can handle our liquor. I don't know what's wrong with Indigenous people. They're just inferior to us. They can't handle their liquor. They're all drunks. What comes from those stereotypes and beliefs is that patronizing. So that talking down, talking to them like they're a child. Again, going back to those, early views of Indigenous people originating in the 1800s, childlike. How Indigenous people were described in those government documents as childlike, incapable. Okay, so that patronizing attitude. What does discrimination look like coming out of that? That's putting those beliefs into action. Now, this piece, we're going to dig into each of these areas because knowing what each of these areas along that pathway to harm looks like can help us inform or help us take steps to interrupt that pathway, to disrupt that pathway. So we're not moving from stereotypes to prejudice, or we're naming prejudice and we're interrupting the harm when that prejudice is put into action and becomes discrimination. Okay, so that's the journey that we're going to be going on in this module. So one of the things that I want to speak about here, going back again to the experiences of Brian Sinclair and Joyce Echaquan and Heather Winterstein that we introduced in Module 1. First People, Second Class Treatment outlines the outcomes from racism having influence along that care pathway. So within that healthcare space, relationship between care provider and patient, and the delivery of those services. If racism is present along that care pathway, these are the outcomes that come from that. So lack of assessment. So you've seen in the case of Mr. Sinclair where he didn't even get triaged. So he's not seen in spaces, in the emergency room, he was clearly invisible. So, this lack of assessment. We talked a little bit about systemic racism and how policies may be leveraged act out that bias, prejudice, and stereotypes. So, in a way that might happen, this lack of assessment, policies may be leveraged to have Indigenous people removed from the space. So, security insisting that they're only there because they're homeless, they need the warmth of the space, they're drunk, they want to sleep it off, and no, you shouldn't be using this. This is not the space for that. Get out on the street. You don't have a legitimate reason for being here. So those are things that could result in lack of assessment. We can have those policies be used in unnecessary ways, as in Joyce being tied to the bed. So, that could be resulting in that lack of treatment coming from the misdiagnosis that they made in that case. We'll dig into that a little bit further. So in the case of Joyce and Heather as well, the misdiagnosis, their symptoms are not taken seriously. The doctor has a different idea about why it is that they're feeling unwell, and the doctor or the care team is not listening to that patient. So again, not valuing what it is that they have to say, their knowledge, and really, discounting and dismissing. So resulting in that lack of, the misdiagnosis. So I believe that this Indigenous person is here because they are intoxicated. They need a place of sleeping it off. So, as in the case of Joyce, and we'll see later as we dig into more of those details, what she's experienced is related to substance use. And, that diagnosis or that care plan, that treatment, that the doctor was recommending coming from that misdiagnosis. And the outcome for Joyce was lack of treatment for what actually ailed her, and ultimately her death. So again, we'll go into a little bit more detail about how racism shows up in each of these cases. So if we're seeing lack of assessment, misdiagnosis, and lack of treatment, that should be red flags. Those should be things that say, hey, wait a minute, I heard that this could be a potential outcome from racism, perhaps having. Okay, so keeping in mind, moving forward, we're going to be on the lookout for that lack of assessment, that misdiagnosis, and that lack of treatment. And we're going to be questioning whether or not racism might have a role in that. Why are we going to question that? Because of how naturalized racism has become in our society. Okay, so racism towards Indigenous people is embedded within Canadian society. Here we have a picture of Justice Marie Sinclair, the TRC chairperson, so the Truth and Reconciliation Commission, looking into the experiences of Indigenous people within residential schools, Indian residential schools. And Justice Sinclair, what he says here is, while Indigenous children were being mistreated in residential schools by being told they were heathens, savages, and pagans, and inferior people, that same message was being delivered in the public schools of this country. So think again, Indian residential schools operated until 1996. Okay, I was 25 years old at that time. I was birthing my first child. Indian residential schools still operated when I was in school. So I was in school in the 70s, early 80s, in those young primary grades, learning that Indigenous people were conquered. They were savages, they were heathens, they were uncivilized, they were conquered, and they were brought into Canadian society, and a favor was done to Indigenous people, because if we didn't do that, they would have been just savages living like animals. That's what I learned in my early education. That's what a lot of people in this country have learned, Indigenous and non. So we really have to remember that when we're looking at how embedded racist views and beliefs about Indigenous people have been taught. They've been taught to generation upon generation upon generation. And really, when we're looking at interrupting harm, we need to recognize that there's unlearning that needs to happen. So, what we're going to do ahead is, look at some of that unlearning, these specifics that we're going to get into in this module, and even more so in the next, is really going to highlight that unlearning that needs to happen. So digging deeper, what's happening with patient experiences. As a person, you know when you're being seen or heard, and you know when you're not. It's the same for marginalized people, Indigenous people. They know whether or not they're being taken seriously. They know whether or not the person is actually looking at them or they're not. They're prejudging them. Again, I'm going to go back to saying, if there's any indication that there is a lack of assessment, there's a misdiagnosis, or there's a lack of treatment, actively question whether or not racism may be in play. This doesn't mean grill, the nurse or the care providers, but it means really think about, what it is that we're covering here, and really employ that curiosity to dig deeper. To ask questions. Look for the influence of bias, stereotypes, and prejudice. What will you see if you're looking and there is bias, stereotypes, and prejudice at play? That's what we're going to cover. So first off, bias. Favored worldviews, values, cultural practices, etc. What is bias? Collins Dictionary defines bias as a tendency to prefer one person or thing to another and to favor that person or thing. So you'll see here I highlighted prefer, preference, favor. Okay, the National Center for Cultural Competence, unconscious bias. So implicit or unconscious bias operates outside of the person's awareness and can be in direct contradiction to a person's exposed beliefs and values. And what that means, that exposed beliefs, it's the front that they put on, how they present themselves in society, what they say, so they may be very particular in saying, I don't have favorites. I don't have preferences. I don't believe that one group of people is better than another. And that may be how they present. So their exposed beliefs and values. Unconscious or implicit bias operates underneath that. So it's something that the person is not actively aware of. It may be something that they don't recognize about themselves. And when you're bringing attention to that, it can be very uncomfortable for a person to acknowledge that. So keep that in mind when we're going ahead, and getting into more detail about how to interrupt this harm. We want to be kind when we're bringing attention to this bias, because going back, how naturalized racism is towards Indigenous people within Canadian society. It's embedded. Everybody was taught similar things. Indigenous people are savages. They're heathens. They're incapable. They're uncivilized. They were conquered. That was common learning across society in general. So, there's unlearning that needs to happen, and that unlearning can only happen if it's supported by kindness and acceptance. Because like I said, people that have this implicit or unconscious bias, that's not how they want to be. They want to be seen as fair, as just, as not showing preference or favor to one group of people over another. What does bias look like? So we talked about how challenging it can be to spot because it's often unconscious, and it can be the direct opposite of a person's values and beliefs that they present, right? So when bias, may be surfacing, it could be that what the person says does not match with what they present in their body language. It doesn't match, what they're saying may not match with how they speak about a person. So if they're saying, I don't favor one race over another, but if they're saying things like those people, or why can't they be like us, how they're speaking about that person is indicating that potential bias. Bias can also be present when they're not open to considering differing views. They're just, it just is the way that it is. Like, I don't know why. I don't know why, it just is the way that it is. So that could be an indication that bias is having influence, and it could be that unconscious or that implicit bias where that individual is being influenced and they're not even aware of that. Stereotypes. So when we look at stereotypes, we're essentially looking at how Indigenous people are commonly viewed. So the beliefs about Indigenous people. What is a stereotype? A stereotype is an often unfair and untrue belief that many people have about all people or things with a particular characteristic. It's a standardized mental picture that is held in common by members of a group and that represents an oversimplified opinion, prejudiced attitude, or uncritical judgment. So you see some things that I've highlighted there. Unfair and untrue belief, standardized, uncritical judgment. Uncritical judgment means that they're thinking this to be true, but they're not questioning how they came to think that this is true. So they're accepting this truth without questioning, without that critical, gaze upon it. You see here a picture in one of those labels, those apples, sorry, is labeled bad. So a stereotype is that mental picture. If we, mention a bad apple, we could see a collection of apples like we see here in this image, and we could see the bad apple as being discolored, as being bruised, as showing, signs of rot. A mental picture pops up. So if a mental picture is popping up in association with something like, the words Indigenous people, that could indicate that a stereotype is having influence here. So we're going to look at what stereotypes show up in healthcare. Over the last decade, there's been quite a bit of work to investigate stereotypes as they show up within healthcare systems, what those common stereotypes are. This list comes from In Plain Sight, which is that report that comes out of BC, looking specifically at anti-Indigenous racism within healthcare. So these were the top stereotypes, or the most common that come up in their research. Less worthy of care. Indigenous patients are seen as inherently less valuable than non-Indigenous, and particularly white patients, due to a number of generalized negative perceptions of Indigenous people. So when I say inherently less valuable, that's just the way they are. They're born with these deficiencies. It's because it's part of their race. They're just not as good at, this, whatever it might be, making decisions or caring for themselves. They're just more susceptible to becoming a drunk because they were born that way. That's leading us into drinkers or alcoholics. So patients are presumed by staff to be intoxicated or to have a drinking problem. And, when we talked about misdiagnosis, this is a common one. So the symptoms of slurred speech, unsteady gait, wobbly on their feet, those can be mistook for alcohol intoxication, when in reality it could be a number of different medical conditions. So relying on the stereotype of this Indigenous person as a drinker or an alcoholic can contribute to that misdiagnosis, because they're not investigating these symptoms further than this belief that they have that this person is just a drinker or an alcoholic. The next one, drug seeking. So patients requiring pain medication are presumed to have ulterior motives. That is, they're only there to get prescription drugs to use for non-medical purposes or to sell. So the only reason they're coming in for care is to get drugs. They're going to take these drugs, they're going to misuse them, they're going to go out there and sell them. They're not here for any other reason. The next one, bad parents. This can be quite common, especially for young Indigenous people, or single parents, where negative judgments are made about the capacity of patients to care for their children. Okay, so we've seen this back when I talked about the epistemic racism and the experiences of Ken and Sonia Salt, and how, the healthcare system is telling them you're a bad parent. You're a bad parent because our ways of knowing, our, biomedical, what we've been taught under that system says this is the best way to treat your daughter, and you're not taking that action, so you're bad parents. Okay, so this is a common stereotype that surfaces within healthcare. Frequent flyers. So patients are presumed to be misusing or overusing the health system, particularly the emergency department. Oh, they're here again. We'll go into what this looks like ahead. So I'm jumping ahead of myself a little bit here. But the idea that patients are misusing, they're overusing, they're not here for legitimate reasons. Irresponsible non-compliers. So you heard me talk about the non-compliant label. So patients seen as unwilling to take responsibility for their healthcare or to follow through on aftercare instructions. They're just not going to do that. We'll dig a little bit deeper into what that looks like ahead. Less capable. Patients are seen as lacking the capability to take responsibility for their healthcare. They're just not able to. And again, thinking back to those, mid-1800s, those colonial narratives that have persisted all this time, Indigenous people are childlike. They need somebody to take care of them. They're not capable. Unfairly advantaged. Patients seen as always getting stuff for free. Now, you heard me talk about the medicine chest clause in Treaty 6. You heard me talk about the agreements in some of those treaties. You heard me talk about, monies held in trust for Indigenous people. Again, because we are childlike and we are not capable of managing something like money. So the government has to do that for us. All of this money held in trust for us is paying for those things that people see us as getting stuff for free. So our prescriptions, our eyeglasses, our dental care, our education. Sorry, I'm drawing a blank here. So all of these things that are connected to those non-insured health benefits or those status card, things that we can get. We're just getting stuff for free because we're Indigenous people, so we're unfairly advantaged. So this is another stereotype that shows up in healthcare. So we're going to look specifically at stereotypes. So prejudice. Prejudice. Well, if you think about that pathway to harm, it's what comes after stereotypes. So it's what stereotypes evolve into, if you want to say. Prejudice are attitudes that are commonly held towards Indigenous people. We look at some dictionary definitions. Prejudice is an unfair feeling of dislike for a person or group because of race, sex, religion, etc. It's an irrational attitude of hostility directed against an individual, a group, a race, or their supposed characteristics. Again, that unquestioned or that uncritical judgment, supposed characteristics. Prejudice is an unfair and unreasonable opinion or feeling, especially when formed without enough thought or knowledge. Again, that stereotype is that shortcutting to the mental image. So immediately believing that mental image that pops up when you think of this thing. So prejudice is really putting those stereotypes into action, into an attitude. So prejudice is evolving those stereotypes in a visible attitude. You can typically tell what kind of an attitude a person has, based on things that they say, based on their body language, things that they may do. Prejudice is those stereotypes, that have turned into that attitude or that have transitioned into attitude. So again, irrational, dislike, hostility, supposed characteristics. These are things that you can pick up on. Does that make sense that this person is saying this about this person? Oh, the way that they've said that, it kind of sounds like they don't like that individual. They don't even know that individual. It's a patient. Why would they have reason to dislike that individual? Wow, that's a pretty hostile way of treating that person. You can recognize hostility when you see it. So things that might indicate prejudice. So it could be physical body language, eye rolling, the exaggerated sigh, the aggressive movements of their self. So they're flailing their arms, an aggressive body posturing. They're standing over the patient in an aggressive way. Or it could be the rough movements of a patient, as they're changing position in the bed. They're not paying any attention to whether or not they're putting too much force on one of their body parts, or their clothing's twisted. They're jerking them around. I heard that a lot from Indigenous patients. Oh, I don't like how they jerk me around. It could be slamming things down, so bringing in medication and slamming the cup down on the tray, the table. Being rough in how things are cleaned up and put away after a procedure. So that dislike and that attitude that they really don't want to be there is coming across in how they're moving things around in that space. It could be moving or turning away from a patient as if in disgust, or it could be ignoring a patient. So, ignoring an Indigenous patient while giving attention to a non-Indigenous. That could be prejudice showing up. It could also be denying a patient's experience. You're not in that much pain. Again, the dislike. So, the irrational. So uncritical judgment, right? So they've made this judgment. You're not in pain, and you're not going to question that judgment because they're discounting and they're dismissing anything else that may come up to challenge that truth that they've taken on in themselves, that prejudice. So we're going to talk a little bit more about microaggressions. Microaggressions, again, are those subtle put-downs, automatic verbal and or nonverbal indications of hostility and distaste. So comments that are hurtful or stigmatizing. So say, for example, as an Indigenous person, I'm going out and, I'm meeting somebody perhaps in my circles, with health leaders and whatnot, and somebody makes a comment to me, oh, you're pretty together for an Indigenous person. Oh, you completed school, eh? Your people must be so proud. So those types of comments that are stigmatizing. Microaggressions are showing preference for others. So like I mentioned before, ignoring Indigenous patient and being warm and welcoming to non-Indigenous patients. This can come across in the tone of voice. So for an Indigenous patient, it may be a very gruff or, just a gruff and can I help you? Whereas a non-Indigenous patient, they may be that pleasant and welcoming. Hi, can I help you? That different tone that they're using, across those different people. They may be overly attentive to Indigenous people in not a pleasant way. So when I talk about this, I'm talking about over surveillance or looking at Indigenous people as there's a high security risk around them. They're here to steal something. They're going to cause trouble, so I'm going to keep my eye on them. In healthcare spaces, it could be nurses, indicating to security and nodding to keep an eye on that visibly Indigenous man over there. Again, believing that colonial narrative that he's a threat to settler society, that he's violent, he's going to be aggressive. So that overly attentive or that over surveillance can be a microaggression. So continue what microaggressions could look like. Somebody telling a very racist joke or making a racist comment and following it up with, I was just joking, or I didn't mean anything by that, or JK, JK, just kidding, right? Microaggressions could be, statements or attitudes that racism doesn't exist because I don't experience it. It could be invalidating someone's experience. Oh, they're just so sensitive. The next one, accusing a person of being oversensitive. Microaggression can be arguing that reverse racism is in play, a white person speaking up about them being treated unfairly. And again, going back to, that idea that Indigenous people, that stereotype that we talked about, Indigenous people are unfairly advantaged. Poor me because I don't have, I have to pay for my medications. This is reverse racism. It's not fair. It doesn't pay to be white in this society. Could be a form of microaggression. Another form of microaggression could be not speaking up, interrupting harm when witnessing racist treatment. When you're not speaking up, if you're seeing something that is happening to somebody else that is unfair or unjust, by not speaking up, you're actually complacent, and you're signaling that you agree. Whether you mean to or not, you're signaling that you agree. You agree with this person's attitudes. You agree with how this person is mistreating this other person. So something to consider as well. Moving into discrimination. So discrimination is prejudice in action. It's the behaviors. So these are things that are more easily observable because they're actions. We look at some definitions, dictionary definitions. Treating a person or particular group of people differently, especially in a worse way from the way in which you treat other people. Discrimination. The meaning of discrimination is prejudice or prejudicial outlook, action, or treatment. Discrimination is the practice of treating one person or group of people less fairly or less well than other people or groups. So you see here in this picture, the image up at the top corner here, there's that figure in red with that circle around them. Discrimination would be targeting that one person that is different, clearly different from those blue figures there, but treating them in a way that is less fair, or treating them in a way that shows prejudice, in terms of those attitudes, right? They're different, so they're not as good as us blue people are. That's discrimination. So we look again at healthcare policies. We talked a little bit about Indian hospitals before. Indian hospitals are good to bring up here again because it's such a clear example of discrimination. What I have out here to read is the introduction to the Separate Beds book put out by the University of Toronto Press. Separate Beds is, resulting from the work of Maureen Lux, and this is the introduction to the book. Separate Beds is the shocking story of Canada's system of segregated healthcare, operated by the same bureaucracy that was expanding healthcare opportunities for most Canadians. The Indian hospitals were underfunded, understaffed, overcrowded, and rife with coercion and medical experimentation. Established to keep the Aboriginal tuberculosis population isolated, they became a means of ensuring that other Canadians need not share access to modern hospitals with Aboriginal patients. So if you think about that time period when Indian hospitals were operating, you think about the work of Dr. Peter Bryce in looking at why TB was so rampant within Indian residential schools. What Dr. Bryce found, the overcrowding, the lack of ventilation, the malnutrition, the lack of exercise, all of those things, that were contributing to the growth of TB infections within the Indian residential school population. The same thing was happening within our communities. So within Indigenous communities, you think back again to the aspects of colonization that forcefully dislocated and removed Indigenous people from their traditional lands, from their hunting grounds, from places where for generations and centuries even, they obtained their sustenance, their food sources. So being displaced onto reserves, being put into substandard housing, housing that had leaks, that didn't have proper heating, that didn't have appropriate ventilation, that was rife with things like mold, overcrowded. These are all things that were contributing to the higher outbreaks of TB within Indigenous people. Racist beliefs said that Indigenous people are inferior. That's why this disease is attacking them harder, because there's just something wrong with them. They're just not as good. They're not going to follow through with the treatment, so we need to keep them separate. They're going to get the settler population sick, so we need to be far away from these sick Indigenous people. That was the rationale for creating this separate hospital system, the separate hospital system that operated for decades. Okay, the separate hospital system that was underfunded, understaffed, overcrowded, where patients were coerced or experimented on without their knowledge and consent. So these healthcare policies, when we look at the colonial context around the healthcare system, the discrimination has been there for decades. It has been there for decades. The belief that Indigenous people need to be kept separate from settler society, is sickness in Indigenous people is a threat to settler society. Okay, so it's, looking at these healthcare policies in that broader context, or the bigger picture around the healthcare system, that really, to me, it really hammers home how deeply embedded racism is towards Indigenous people within the healthcare system. So we talk about reality today for Indigenous people. This information is coming from a StatsCan publication, 2024, and what it says is roughly 1 in 5 Indigenous people report experiencing unfair treatment, racism, or discrimination from a healthcare professional. 1 in 5. Racism, discrimination, and marginalization within the healthcare system are documented barriers to healthcare for Indigenous people. About 24% of First Nations people living off reserve, 23% of Inuit, and 18% of Métis reported that they experienced some form of unfair treatment, racism, or discrimination from a healthcare professional in the 12 months prior to the survey. First Nations women living off reserve and Métis women were nearly twice as likely to report this compared to men. Okay, so that's our reality today. 1 in 5 Indigenous people are experiencing unfair treatment, racism, or discrimination from a healthcare professional. So what that's speaking to is speaking to that interpersonal racism. It's not accounting for the epistemic racism. It's not accounting for the systemic racism. It's not accounting for the influence of internalized racism. All of these forms of racism are contributing to those outcomes. Lack of assessment, misdiagnosis, lack of treatment, and death. So we're going to dig a little bit deeper into this pathway to harm, and hopefully you've seen how this progresses, this pathway of harm progresses from colonial ideology or worldviews, or sometimes, like I like to say, colonial narratives, how that progresses to stereotypes and beliefs, how stereotypes and beliefs, they evolve into prejudice or attitudes, and how prejudice evolves or contributes to that discrimination. So how those attitudes are put into action as behaviors, and that is where the harm is occurring. So the examples that we have here, and again, this is coming from work of Dr. Cheryl Ward. So an example of the worldview, they are inferior to us. So they being Indigenous people, they are inferior to us. So the belief that comes from that worldview, they are slow learners. They're just not as good as we are. They're not as smart as we are. They're just slow learners. What is the attitude that comes out of that belief? Patronizing, pity, looking down on, talking down to, sorry. The behaviors that can come from that patronizing, that pity, those attitudes, Indigenous people are invisible. They're ignored, like Brian Sinclair. They're labeled, like Joyce Echaquan. We'll dig into a little bit deeper about how she was explicitly and very blatantly labeled. So those behaviors that contribute to that harm, and in the case of Brian and Joyce, their death. Again, another example, the colonial ideology or the world view. They benefit from colonization. Indigenous people, they benefit. The stereotype or the beliefs that come from that worldview. Oh, that's just another one of those kids looking for free stuff. Oh, they're just looking for free drugs. Oh, they're just here because they get a free ambulance ride into town from their community. The attitudes that come from those beliefs, anger, resentment, hostility. They're taking something from us, so I'm angry. I don't like that they get something for free and I have to work for what I have, so I'm going to be, resentful. The behaviors, the violence, the aggression, the maltreatment. One more example, if you're up for it. I know this is a little bit heavy stuff, but when we really look at these different components of the pathway to harm, that's the knowledge that is going to be empowering us to interrupt, to disrupt this pathway and to prevent that discrimination and that harm. So again, those outcomes of lack of assessment, misdiagnosis, lack of treatment, and death. So, colonial ideology, worldview, another example. They are just biologically different. Biologically different. That's the inherent that I talked about before. They're inherently this way. It's their biology. The belief that may come out of that, they're all drunks. So there's a lot of things going around that are saying, oh, Indigenous people are all drunks because there's something in their biology that makes them more susceptible to alcoholism. The attitude that comes from that disgust, that contempt. They're different than me, and I don't like what's different from me, and they're different from me in a very ugly way. They're drunks. So that prejudice and those attitudes that are coming out of those beliefs, that prejudice in action, the discrimination or the behaviors, avoidance. I don't want to deal with that person. And we've seen that clearly in Brian Sinclair. I'm walking around him. I'm assessing the patients beside him, but I'm not looking at him. I'm not going to go over it and see if he has a band on his wrist because I think he's just a drunk. So I'm avoiding him. I'm going to deny him care. There's misdiagnosis happening there, like we'll see later in the case of Joyce. So, the outcome from that in the case of Brian and Joyce and many, many others is death. So that's the pathway to harm. I'm hoping that our time together today has really broke down those different components, and you're able to see how they build upon each other. So how you start with this worldview or this colonial narrative, this way of thinking about Indigenous people, and how that way of thinking turns into stereotypes and beliefs, and how those stereotypes and beliefs turn into those attitudes, that prejudice towards an Indigenous people. And that harmful piece, that discrimination, the behaviors, the behaviors that are contributing to those horrible outcomes that we've talked about a few times now. So what's next? We're going to look closer at stereotypes and how they show up in different types of racism. So we're going to look at systemic racism, and we're going to look at how those stereotypes that we talked about a little bit ago. I'll show you here again. So these common stereotypes, we're going to look at how these common stereotypes show up in systemic racism. We're going to look at how these common stereotypes show up in epistemic racism, interpersonal racism, and internalized racism. So, what is it in these different forms of racism that are going to indicate the influence of bias, stereotypes, and prejudice? And hopefully, after we get through that next module, we'll be able to name this is a stereotype because of this reason. I think this is bias. I'm going to question this a little bit because this is what I'm seeing. This is what I'm observing. This is what I know. Okay, so really what we're digging into by looking a little bit deeper at these stereotypes is we're looking at those tools and empowering ourselves to really name racism and the influence of racism in a way that could potentially disrupt that harm and those outcomes that we talked about. Again, the lack of assessment, the misdiagnosis, the lack of treatment, and death. So we've got some time here within our hour. What I'm going to ask you to think about in preparation for our next time together is just to look around, as you're going about your daily, life, whatever it might be, whether it's at work or listening to media, watching television, reading the news, whatever, and just look for, these stereotypes and see if you can recognize them. See if you can pick up when, they're maybe highlighted or brought attention to, or even just think about them, just roll them around in your mind, what they mean, what they might look like, so that you're maybe you'll have it all figured out by the next time we're together, how these different stereotypes are going to show up within systemic racism, epistemic racism, interpersonal racism, and internalized racism. So Miigwech, thank you for your time today, and I look forward again to our time together next time.